Good. So, hello everybody. Hope life is treating you gently in this pretty rough times. Welcome to this premiere of a series of case-based webinars organized by WINFOCUS. So I basically, there's no need to say how there is a need in this difficult period to discuss, to share, to have opinion guidance available to clinicians on the use of point-of-care ultrasound. And today we're in fact focusing on point-of-care ultrasound use for COVID-19 patients with respiratory failure, acute respiratory failure. And we're lucky enough to have Alberto Goffi. Welcome, Alberto, and thanks for joining us. How are you doing?
Welcome, everyone. Thanks for joining and thanks for inviting me.
And also thanks, Anthony Dean, for helping us carrying this through. Thanks to Davide and Queen for setting up all the logistics. So basically, Alberto, just a brief introduction, is a staff physician at St. Michael's Hospital in Toronto. He is assistant professor at Toronto University and the Department of Medicine and Interdepartmental Division of Critical Care Medicine, again in Toronto. For those of you who don't know him, Alberto's interest is in neurocritical care and point-of-care ultrasound, and specifically on the clinical utility of PoCUS in critical care and teaching, and also, let's say, developing strategies for achieving competence in point-of-care ultrasound. Alberto has traveled extensively in the world, teaching PoCUS, also in developing countries, and he publishes regularly on the topic. Just a few notes to let you know who Alberto is. The way the nurses in his ICU, the way they named him, or better say, the way they named the ultrasound system they were using, it was Alberto's second love. And why the second? Well, because the first was basically died due to an excessive use and consuming use by Alberto himself. Alberto, you can confirm this.
Yeah.
So please, Alberto, introduce us to the topic.
Years ago, they actually brought.
Yeah, they bought a new one, which is the one you're using now. Great. So it's going to be a two-parts webinar. And before I give you the mic, just a technical note. If you want to make questions, please use the Q&A feature of the Zoom platform you're using. If you have technical issues, please use the chat, and we'll try to answer on the fly. But in any case, in the end, there's going to be time to discuss, and we'll be happy to welcome your questions. Alberto, please, the mic is yours.
Thank you, Gabriele. I'm going to stop the video, so hopefully this is going to improve the quality of the transmission. It's a real pleasure, Gabriele, being here today. Thanks, Anthony. Thanks, Davide. Thanks, everyone, for joining. I saw from the audience there are a lot of very well-known experts in point-of-care ultrasound, so a little bit of daunting experiences presenting in front of this panel. As Gabriele mentioned, feel free to interrupt anytime, ask questions to the Q&A, to the chat. We are trying to make this as much as possible interactive and to really benefit from everyone's experience. I'm pretty sure that many of you have seen more COVID patients than I did, because fortunately Toronto was pretty sparse so far. We had a peak, but nothing compared to Europe, US, or South America so far. Okay, so in terms of disclosures is that I collaborate with other societies outside WINFOCUS. I'm the vice chair for the SCCM Ultrasound Committee. I'm a member of the Canadian Critical Care Ultrasound Consortium, but none of this affiliation is going to affect my presentation. The only really conflict of interest is my daughter, that you can see. She was 1 year and a half, and she was already playing with a phase array probe. And this is unfortunately something that runs in the family, I believe. As Gabriele mentioned, when we started preparing this webinar, we realized that there was a lot of talk about it. And we therefore decided to split the webinar in two parts. The first part is what we're going to focus today. and there's going to be a second webinar. So they're truly focusing on the use of point-of-care ultrasound in the management of patients. We are going to discuss about the recruitment maneuver. We're going to discuss about proning and other critical intervention that we do in the ICU. The first part that we're going to discuss today, it's going to be focusing on the use of ultrasound for diagnosis. Of course, diagnosis of COVID pneumonia, and then the detection of complication associated with COVID-19. And we will try to do this through a mix of case description and review of the incoming literature, because really every day there are new articles published on the topic. So question number one is that can ultrasound diagnose COVID-19 pneumonia? Can we use this to diagnose reliably and effectively with specificity and sensitivity COVID-19 pneumonia? Well, let's start with two typical cases. For the ones that are not familiar with scanning protocols, this is the terminology that I'm going to follow during my presentation. You see here, there are many scanning protocols described. So I usually use these 8-zone or 12-zone protocols, where I essentially divide the chest in anterior, lateral, and posterior zone, and I divide the chest in superior and inferior. So every time you're going to hear zone 1R, for me means that is ventral zone, so anterior zone, superior. When you hear about zone 6, it's going to be posterior, usually at the base of the lung, so in the costophrenic angle, and can be L for left or R for right.
Alberto, just one question.
Yes.
Are you scanning all intercostal spaces when you refer to a zone? That's something people may want to know.
Usually I do as much as possible. And again, I think is that the vast majority of the literature is clearly saying that what you do is that you scan as much as possible the entire area that you identify as zone 1, and then you focus on the worst for scoring purposes.
Good.
For other applications, I'm really scan as much as possible. It doesn't take much, even if you scan all the intercostal spaces, to identify subtle findings, especially in the context of, for example, suspected pulmonary emboli when I'm looking for pulmonary infarcts, or other more scattered findings. So the answer is yes, as much as possible, I try to scan everywhere. What do you do, Gabriele?
Well, I do the same, I would say. But it depends on the protocol. I mean, or the situation. If you're going very fast, you could do the simple. I mean, the same way you use the stethoscope, just put it in the center of the zone and get the finding there. But especially, I think when we're talking about COVID and the kind of pneumonia it is, especially in the early phases, scanning all intercostal spaces is so important to pick up also the findings in known very severe pneumonitis. This is what I believe.
Perfect. Okay, so let's start with the first case. This was a gentleman that I saw on a Saturday morning, early morning, back in April. Typical risk factors: male, in late 50, with history of diabetes, hypertension, that comes to the emergency department with severe respiratory failure. Essentially, we intubated him in the emergency department, brought out to the ICU, and rapidly deteriorated for a severe respiratory failure. As you can see from the chest X-ray and from the CT scan, quite typical findings for COVID pneumonia with the peripheral ground glass opacity and crazy pattern and basal consolidation. So let's have a look at how his lung ultrasound look like. And again, here we are seeing anterior zone. Again, right anterior superior, right anterior inferior, left anterior superior, and left anterior inferior. Gabriele, what do you think? If someone sent you these images remotely and asked you an opinion, what would be your comments on the key feature that you see in this patient?
They would be concerned comments, because I don't see any single scan which looks normal. This is my first observations. I would say they're all artifacts. So there's no, at least in these scans, any image, but they're all artifacts, and they're quite pretty pathological ones. I think you want to head us, you want to lead us to the B line is something important there, because I see so many of them. Correct.
Perfect. So what I'm hearing a bilateral involvement. I'm hearing that is diffuse bilateral involvement in all the quadrants so far we are imagining. And we see significant presence of vertical artifacts that they qualify for the B-line definition. In terms of B-lines, you think that they are separate, they're confluent, they're both?
Well, one of my concerns is the abundance of these B-lines and not only the coalescence, but the fact that they occupy most of the pleural line, which is a good criterion for something more than separate B-lines, not just only the fact that they're separate, but the percentage of the pleural line that they occupy is an important finding to me. Excellent.
So we are adding now the information that we have bilateral, diffuse B-lines that there are coalescent, or again, as Gabriele was mentioning, that they completed like in a white lung picture. And in other areas, we can still, for example, see as L1, you can see that the B-lines, they are sort of separate still. And maybe you can see a line at this level here, talking about what we may define like lung heterogeneity. One last question before we move to the next is that, what do you think about the pleural line, Gabriele? Does the pleural line look normal to you?
Oh, well, that's the other bit. So we're moving progressively into a deeper analysis there. And it doesn't look normal in all the scans, and I would say even pathological in most of them. If I think about my normal scans, it looks quite thick and irregular. This is what I would notice.
Excellent. What about here?
Well, are you making an interrogation, Alberto? That was not in the plan.
Well, I tricked you. I didn't tell you, but that's what Anthony asked me to do. What about these areas here? So now we are moving laterally, okay? So R3, R4 for me are the areas identified by the anterior axillary line and posterior axillary line. I think we all can see is that this pattern is repeated. We have, again, bilateral involvement diffuse with significant presence of B lines. And what Gabriele was mentioning about the irregularity of the line, look at here, at this point here, you see that it looks like interrupted. There is a hypoechoic error, look like the proline is not continuous. Or even here, now we can even see a subpleural peripheral consolidation that is clearly visible. And then finally, when we go at the level of the posterior and costophrenic angle, you see here that there's not much effusion, to be honest, I could see. And actually, I almost don't see at all. And by seeing the diaphragm, you see that there is this transition zone. This is a little bit larger consolidation, but definitely not a ginormous information. So Arif is asking, what clinical info do you have at this stage? Well, we didn't know his COVID status. Of course, is that the pretest probability was pretty high by looking at chest X-ray and the CT after. We knew about his risk factors, and we know that it was a profoundly severe respiratory failure. That's all we knew at this point. It was hemodynamically stable at that time, a single organ failure, only respiratory failure. It then progressed, and I'm going to show you during the presentation. It progressed, unfortunately, to multiple organ failure with requirement for renal replacement therapy and shock. But at that time, he was an undifferentiated patient, of course, at the peak of our first wave in Toronto, with a high pre-test probability of being COVID positive for both images.
Respiratory failure, yeah.
And exactly. So essentially what Gabriele just described is what has been described now in many articles. And I'm using this reference. There is a very insightful article that I recommend you, all of you to look. It's very short, that is describing the lung ultrasound findings in COVID pneumonia for Giovanni Volpicelli. Essentially is that feature number one, as you saw, is that you're gonna see B lines. They can be separate, they can be coalescent, providing this picture of a white lung. And an interesting description that Giovanni Volpicelli described in this article, and is then been repeated by other authors, is what they call the live beam artifact. So at first, I can tell you is that when I was reading the article, I was thinking about this finding and say, oh, yeah, this is just coalescent B lines. Why Volpicelli thought that this should be considered a separate lung ultrasound finding considered from the coalescent B line. So have a look at the first video here. You see what happened is that the proline looks, compared to the one that I show you, pretty homogeneous. It's thin. We don't see those irregularities that Gabriele described in my case. And suddenly, from a normal looking proline, we have this wide band vertical artifact that are, again, most likely behind the coalescent, but they originate from a normal looking proline, interposed with normal line. In this other loop here, and both loops are available in the publication from Giovanni Volpicelli, you see there are two different band-like artifacts. One here on the left of the screen, and if you observe the proline is not as smooth as in the other videos, or on the right side. So the definition that Giovanni provides in this article about the light beam is exactly this one, is that this wide, large band-like vertical artifact originating from the proline that looks like normal, and that artifact is interposed between areas of normal lung. This most likely on CT, I'm going to show you some images, is the depiction of what we see on CT when the patient presents with diffuse ground glass opacities without having crazy Pavi pattern or without having yet peripheral consolidation. And then, of course, we have the irregular fragmented proline, the consolidation that, especially in the early phases, are small and not lobar as in other type of pneumonia, and rarely large perfusional presence. And of course, as we noticed since the beginning, this bilateral distribution is patchy and is multilobar. Can we use this as an
Alberto,
yes.
Yeah, basically you're telling us we should focus on this single specific sign, the B line, the light beam, the pleural modifications, small consolidations, and one important concept that I understand you're stressing is a distribution, the way they are represented throughout the entire lung surface, correct?
Correct, correct. And I'm gonna show you in a few slides that these are the key features, but unfortunately they are not necessarily specific. So lung ultrasound, can we use lung ultrasound as an alternative to CT? There are now many articles published with many nice pictorial representation where you can correlate clearly the feature that I just showed you with actual CT imaging, the consolidation, the ground glass opacity, the Cravi busy pattern. This article is actually not published officially yet. It's a preprint that Gabriele sent me literally this morning, and I decided to add it on the last minute because I think it's one of the most well-conducted studies on comparison between lung ultrasound and CT that I've read so far during this pandemic. It's a study from Amsterdam, from the Netherlands, 2 centers. So they identified 34 patients, and for this single patient, they had 55 pair lung and CT examination. And what they did is that they calculated what they call the lung ultrasound score index. I'm pretty sure that you're all familiar with the lung ultrasound score. Is the original score described by Bouema, the Jean-Jacques Ruby, when for each area you give a score from 0, normal lung, to 3, a large consolidation seen on that single area that you're scanning, multiplied by 12 different areas, give you a score from 0 to 36. The problem with this,
Alberto, to
yes?
disambiguate a little bit, it is not the reaeration score.
No, it's not the reaeration score. So the reaeration score was used.
That scores the single finding at a single frame. Let's call it this way, right?
Correct. Essentially, is that, and just to clarify this, is that the reaeration score will use, I'm pretty sure, and again, the Blue Journal paper in 2011 from Bouemad, where they correlated the changes in PEEP with reaeration. And there was also another study looking at, I think, the resolution of pneumonia in the context of antibiotic treatment. And you need 2 time points. You need time 0 and time 1. You compare the same area, time 0, time 1, and based on the changes, better or worse in aeration, you can calculate what is called the re-aeration score. The same group in other studies, they instead use the lung ultrasound score, where you just need one single time point. Is that you look at the image like looking at a picture right now, and I say, okay, this area here is normal, 0 point. I see more than 3 B lines, but there are not so many, they are not coalescent. Jean-Jacques Ruby called this the B1 pattern, and the score is 1. You do this for 12 areas, 6 on the left, 6 on the right, and the total score will give you the lung ultrasound score. What is the difference between lung ultrasound score and lung ultrasound score index? Well, I think is that you're all familiar with this. In some patients, because of dressings, because of chest tubes, or just because it's impossible to scan some areas, you cannot have all the 12 areas. And so your score, let's imagine that I cannot imagine a patient 2 areas, my score will go automatically for 36 down to a max of 3330. And I cannot compute that score with patient when instead I have the 12 areas. So what they did, they standardized. And so what they did is that they divided their score for each patient by the maximum achievable score in that specific patient. Again, let's imagine I have 27 points in a patient when I only have 10 area. It will be 27 divided 30, multiply 100. It will give me a percentage of lung involvement in terms of score. So what they found is that this lung ultrasound score correlates pretty well with a CT score severity index. That is, I think is the most commonly used radiological CT scoring that our radiologists across the world are using right now for classification of severity of COVID-19 pneumonia. You can see here quite good regression correlation. They also show that you can follow the changes in lung aeration over time, and these correlate pretty good with 0.81 concordance, 81% concordance between the lung and the CT done at the same time. So the conclusion of this article, again, is not being accepted. It's a preprint. And again, it's still 55 examination, better, but not as large number, is that the lung ultrasound score index has a strong correlation with CT index. They also did a separate analysis when they look at 6 zone versus 12 zone, and they perform similarly. You can reliably use lung ultrasound to follow in sequential examination the resolution or the changes in the aeration as you could do on CT. And again, here the numbers are small, but what they found is that high pulmonary involvement on lung ultrasound, not just on CT, was predictor of ICU length of stay. And again, not surprising from this perspective, but they managed to demonstrate this. This is a busy slide. I will not really focus on this one. Again, yes, you can use potential lung ultrasound as alternative to CT, but don't forget that CT and lung ultrasound, they have both advantages and disadvantages. Detection that abnormalities that they do not extend to the pleural surface, they cannot be seen on lung ultrasound. The mediastinum cannot be imaged appropriately on lung ultrasound. And the lung ultrasound, the learning curve is steep, is relatively easy to learn, but still is operator dependent. So the decision to use lung ultrasound and CT chest, I think, is still not completely resolved by the current literature, but I do believe as every test has a pro, has a con, and based on your clinical picture, you need to decide what to do.
Alberto,
okay, so yes.
Can I make a comment, Alberto, on your last 2 slides? Because as we know, lung ultrasound basically works assessing the density of the superficial layer, most superficial layer of the lung, right? So as you were saying with this slide, basically lesions that are not above the surface will be missed by lung ultrasound. So it is a question whether lung ultrasound can really assess the overall level degree of aeration of the lung. Because there may be lesions missed by lung ultrasound that, of course, CT scan will not miss. And apparently from the data of the preprint you presented, this is not a major issue in COVID-19. And I think one of the, if those data are confirmed and will be confirmed of larger populations, it is not a big issue because as we know from the first CT scan series, and they're coming out many on radiological journals in these weeks, COVID-19 pneumonia actually expresses mainly or always at the surface. So this may somehow blunt or reduce the impact of this discrepancy in the capability of lung ultrasound to assess the deeper areas of the lung when we're talking about artifacts in comparison to CT scan. Do you agree with this?
Correct. I completely agree. I think is that in the specific case of COVID-19 pneumonia, because of the features of the disease and this predominant peripheral pattern, lung ultrasound and CT scan correlates better than other conditions. Years ago, I think it's on chest, it was published a cohort of patients with pneumonia following lung ultrasound and chest X-ray by Angela Reisig. And I think in that cohort, there was still a 7% of false negative pneumonia not detected on lung ultrasound. I really believe that it depends by the disease, it depends by the condition. And as you mentioned, in COVID-19 pneumonia, we may be not lucky, but I think is that the correlation will be higher than in other pathologies because of the specific features of the COVID-19 pneumonia. So teaching point number one is that we have definite findings and there is good correlation with CT. However, and there was a question in the Q&A that I did not respond at the time because I had this slide, is that the question is that, are these findings specific? Are they truly specific? Can I diagnose COVID-19 directly on lung ultrasound, avoiding RT, PCR, or just by saying, well, let's do another case. This is another patient presented with severe respiratory failure in the emergency department. Previous allogenic stem cell transplant for acute myeloid leukemia. She was on severe respiratory failure, started 92% on 70% FiO2. In this case, there was a shock component requiring a relatively moderate dose of norepinephrine, 0.15 mics per kilo per minute. Volume control. If you look at the driving pressure, she had a significant driving pressure. The people 14 at plateau 34. And question for Gabriele is that by looking at this lung ultrasound, you find it very different from the first case I showed you. And again, that's what we know so far. We are waiting. We sent all the, because she's immunocompromised, we did a BAL despite the pandemic. Any significant difference, Gabriele, here?
Well, at a first glance, I seem to find the same, I would say the same degree of involvement of this lung, of the pathological process. I mean, there's a lot of B lines. They seem to be coalescent in all the scans. They seem to occupy a relevant part of the pleural line. I think you're moving laterally now. And yep. We see appearing some pleural irregularities. There's some consolidation back on the right side. I see some subpleural consolidation. So altogether, I wouldn't say there's such a huge difference in the two overall lung ultrasound patterns of these two patients. So it could be COVID-19 pneumonia.
Do you think that she may have COVID-19 pneumonia?
Well, I would like to receive a different question. Do you believe this lung ultrasound pattern is consistent with a potential pneumonia caused by SARS-CoV-2? I would say yes, it is consistent, but I can't tell you whether it is COVID-19 pneumonia.
And I completely agree. And the bottom line is that this case actually was a patient I saw back in 2013, and she was H1N1 ARDS. And for the persons that were asking about the specificity, Well, not even CT in specific. Every time I ask for a CT in my hospital, in the report, there is a line, a medical legal disclaimer essentially, when they're saying is that you cannot diagnose COVID-19 pneumonia on CT. Because despite the features are very, very, very suggestive, nothing has been shown so far to be absolutely completely specific. Even the light beam artifact, if you read the article from Giovanni Volpicelli, he specifically say that even the light beam can be found in other conditions. And I agree with him, essentially, because that is the representation of ground glass opacity with normal lung parenchyma around. And this is something that you see in the differential. When the radiologist give a differential of ground glass opacity is extremely long. It's not just one single disease. This study published, that will be published in 2021, but it is already available online from American Journal of Radiology. He looked at the comparison between COVID-19 and influenza patient. They retrospectively look at a cohort of influenza patients. And you can see here, yes, as Gabriele mentioned, peripheral lesions are more frequent, but not present in influenza. Mucous impaction, I don't care. I don't see it very well on lung ultrasound. And to be honest, I'm not sure how to interpret mucous impaction in the context, especially patients that are mechanically ventilated. Pleural effusion is another feature that it's less common, and I think it's experienced for every one of us in the early phases of COVID-19 pneumonia. Everything else, ground glass opacities, the potential light beam, the crazy paving pattern, they are not different in COVID-19 and influenza. Presence of consolidation, the sensilobular nodules, they are all the same. And that's why when we think about the characteristics that Gabriele and we sort of pointed out in my first case, the confluent B lines, the light beam, the small superior consolidation, the pleural line irregularities, the lack of large pleural effusion are not specific for COVID pneumonia, but are present in many interstitial infectious viral, for example, pneumonia, and not just in viral pneumonia. Is that if you go back to this article in 2008 from Petty and Soldati, when they compare patient with heart failure and patient with ARDS, patient with ARDS had this lung heterogeneity, space area, the heterogeneous distribution of the B lines with coalescent and space. They have pleural line anomalies. They have superior consolidation or peripheral consolidation. All features that you can also see in the COVID-19 pneumonia. So, Alberto, unfortunately, and then I'm going to give you, is that my answer to this is yes, we are definitely findings. Yes, they correlate very well with CT, but they are not specific. Yes, Gabriele.
Can I make a comment, Alberto? So, both the cases you showed were likely patients with an extensive lung involvement, right? So, cases of pretty severe pneumonitis, viral pneumonitis, diffuse bilateral, with all the characteristics of an inflammatory edema that you were just highlighting, recalling the paper by...
So in the spectrum of the severity, they were severely healed COVID-19.
They were severely ill. So they likely have not been scanned and assessed at an early phase of the disease. And I'm saying this and I'm highlighting, I'm underscoring early and a potential issue related with timing of the exam, because I am particularly intrigued by Giovanni's description of the light beam. In the case series that actually he alludes to in his publication, he's quite convinced in saying that there's a certain degree of specificity that he is about to study. He's studying, we had some chat amongst several colleagues, and Giovanni mentioned that there's an ongoing trial trying to investigate the accuracy for COVID-19 pneumonitis of this specific sign and others. So my question, and I really am intrigued by this, is couldn't it be a matter of a different timing of the exam? So Could that be a sign that actually appears early, and that after that, superimposing inflammatory worsening of the lung changes the pattern to a different presentation, which becomes not anymore sufficiently specific? Could that be possible in your opinion?
I think that the answer cannot be answered completely, because we need more data. I think we need science on this. From reading the articles, by my personal experience, by looking at the correlation with CT, that we don't have to forget is still the reference standard for us. Ground glass opacities, especially when you have a focal area of ground glass opacity without crazy paving pattern. For the people that don't know what is ground glass opacity versus crazy paving pattern, is that ground glass opacity is that when you have this appearance of the ground glass on CT with normal preservation of the architecture of the lung. Essentially, I have something that is affecting my alveoli, but I don't have disruption of the architecture of the lung. And I'm not a radiologist, so if anyone knows more than me, feel free to comment. But the crazy paving pattern is like those stones that you see in all cities in Europe. When you have the ground glass, and around the ground glass, you have thickening of the interlobular septa. So my point to this is that maybe Giovanni's study is going to be positive because the epidemiological landscape we are living. If someone shows up right now with that pattern, 90% of the time it's going to be COVID, especially if you are in Brazil, especially if you were in February in Italy, or if you are in Texas right now. But I am actually curious to see what's going to happen in 2 years, 3 years, or even during the fall, when you're going to have co-influenza and COVID-19 presence. Honestly, I don't know, but my interpretation is that, and I'm going to show you some data as well in the early phases, is that the light beam is extremely sensitive for interstitial involvement, the with ground glass opacities, but it's not specific for only COVID-19 pneumonia. And in Giovanni's ultrasound journal article, he writes that.
Good. So basically now, I think if I get it right, you're trying to move us from these single ultrasound findings to a clinical ultrasound integrated approach.
Correct.
In these kind of patients, which is what we usually do with point-of-care ultrasound when applied correctly, right?
And that's the beauty of WINFOCUS and WINFOCUS approach, right? Is that we are not just radiologists, we are clinicians. And I'm going to show you specifically, next slides are specifically designed for this concept. So the question is that, so that's what we're discussing. So, okay, that's it. We sure definitely findings correlate with CT, but it's not really useful for diagnosis. That was my question initially, right? Is that, so this is a nice figure that Gabriele, I'm stealing from Gabriele and Arif was saying, they prepare for a publication that hopefully will be published soon, where essentially they imagine the possible scenarios that we face every day in our emergency department, in our primary care practice, in our hospital and wards. And if you can imagine, there is scenario number one. Someone coming with symptoms, respiratory symptoms, I do a lung ultrasound and I see exactly what they just showed you. And I even see light beam. The question is that COVID pneumonia, yes or no? And of course, we do RT-PCR, and as you can see here, two possibility, there is concordance between COVID RT-PCR, that's great, diagnosis is done. But what to do when there is discordance, when the COVID-19 RT-PCR MPs in the nasopharyngeal swab is negative? Or other scenario number two, is that the lung ultrasound is completely normal. And I think there is a risk here is that people that say, oh, lung ultrasound is normal. This guy does not have COVID-19 pneumonia. And I'm going to show you some data on this. Third scenario is that I do a lung ultrasound and I don't see that specific, again, we should not use the specific, that characteristic pattern that we just show you with the B-line, line beam, the peripheral consolidation, the lack of prorefusion, the lack of large consolidation. And then that's it. This patient has something else, doesn't have COVID then, right? Is that there is the risk that we can rule out or rule in the infection with the lung ultrasound. So let's, as Gabriele was mentioning, is that in my way of thinking, lung ultrasound, as much as I love ultrasound, is just another tool. It's not the holy grail. I cannot be biased because I love a technology and I use it for everything. And that's one of the risks. I need to consider the epidemiological landscape that I'm living in, if I'm a high prevalence or low prevalence. When in Toronto, we didn't have local transmission yet, and everyone was waiting for the first COVID cases. The first 3 patients that I intubated with severe respiratory failure and interstitial changes on CT, I was convinced, oh, this is COVID, it's come. None of them has COVID. None of them had COVID. One was strep pneumonia. The other one was a cocaine crack inhalation on injury. And the third one was, I don't even remember, but none of them had COVID because our prevalence was so low that everything else was still more common. Then I, knowing my epidemiological landscape, I start having a pretest probability. And then I also do my clinical assessment. I do physical exam, I do history, and I use lung ultrasound to increase my pretest probability. And then, of course, we have the RT-PCR, the PCR that is helping for this. So I don't know if you're familiar with the data on RT-PCR, but the clinical sensitivity, that means is that if I have 100 patients, I do RT-PCR on these patients, not on a sample, on a patient, the PCR false negative tests, they varied in the literature from 2 to 30%. 30% means that essentially it's 3 out of 10 patients that you do an RT-PCR, they have COVID, but your PCR comes back negative. And why this is important? This is important because you are going to have potentially false negative patient. You're going to discharge home. You're not going to isolate in your hospital, in your emergency department, at home, in the community, and they're still going to be spread. And the problem is with this graphic from the New England. Look at here, is that the sensitivity, let's imagine the worst scenario, sensitivity of 70%. So I have someone that's sensitivity of 70%. If my pretest probability that this patient has COVID is low, then it's great. Or at least is I can trust the test, because if my test come back negative, my chances of infection given a negative test result, so how much can I trust a negative result, is pretty good. It's 5% error. So it means that 95% of the tests that are negative are truly negative, true negative. But when my chances of infection increasing, because of lung ultrasound, for example, or because of the epidemiological scenario, I am in Bergamo during the peak of the outbreak in Italy. Everyone that was coming with those symptoms had an extremely high probability of COVID. At that point, when I'm here, 30%, 50% probability, or even 30%, if my PCR comes back negative with a sensitivity of 70%, the actual probability that this patient is not infected, it's much, much lower. You see here is that the chance of infection are now 15%. Is that it means that 15% of the time, my RT-PCR in some of our pretty probability of 35% are going to be wrong. And if I don't be careful, I'm going to discharge this patient. I'm going to not cohort this patient, and that's going to be a disaster. So a single negative COVID-19 test, this is sort of the statement from the New England article, should not be used as a rule out in patients with strongest suggested symptoms. So Emanuele Pivetta, there is a close friend of mine, a great scientist, and myself with a group of people from Torino, University of Torino in Italy. During the peak of the pandemic in Torino, we tried to test this hypothesis. And what we did is that we enrolled 228 consecutive patients coming to the emergency department, and we did exactly what we do routinely. We ask ourselves, based on story, physical exam, and the exposure that this patient had, is this patient likely or unlikely to have COVID? And then we added lung ultrasound. And these are the results. They're a little bit complex figure, but I'm gonna try to follow me. So look at here. This is a patient with high clinical suspicion, where we did lung ultrasound, we found those findings we were discussing with Gabriele. And out of 88 in the high clinical suspicion group, out of 19 in the low clinical suspicion group, the RT-PCR was negative in 29 and 6 patients. Consistent with what we show you I show you the 2 to 30% false negative rate. Here was 15%. Actually, we are better than some other studies. But this patient, because there was discordance between lung ultrasound and RT-PCR, we didn't stop. They went for bronchoscopy, they went for repeated study, they went for repeated PCR, and out of 21, 17 in this high clinical group, and out of 6, 4 in the low clinical group, they had COVID with the first negative PCR. So
lung ultrasound was right in those cases.
Lung ultrasound was right in those cases. Yeah. Lung ultrasound was right in identifying an interstitial involvement that, because of the pre-test probability, we were at the peak of the pandemic in Torino, it was COVID. Not right all the time. You see here, 2 and 4, so 6 patients, we were wrong, but still, okay? So the way I can see it is that if I have discordance, I need to think exactly what Gabriele was showing and Arif was showing you here. I remember the first scenario is that the patient with lung ultrafine signs suspected, COVID negative, PCR, do not stop, keep looking. And these are the data demonstrating it. The other aspect,
let me stop you for a while and just say that it's also message that comes from situations where, and this is published, CT scan is positive, RT-PCR is negative, and correct. You follow the same kind of
correct. There's no different. Right? There's no different from the study done on CT. I'm just telling you that you can do this on lung ultrasound without moving the patient and going for CT. Absolutely right. But be careful, okay? Because negative lung ultrasound, scenario number 2 from Arif and Gabriele figure, does not rule out completely SARS-CoV-2 infection. In our cohort, okay, early patient, they were patient in the emergency department, the patient with the high clinical suspicion, if your lung ultrasound was negative, okay, negative lung ultrasound, so no pneumonia, they still have an infection. And remember is that there's a lot of asymptomatic patients. There are a lot of patients that they don't have pneumonia. And we are discovering more and more that the data from the CDC is that it looks like the prevalence of the disease is 10 times higher than we think. These patients, they don't have most likely lung involvement, but they still have positive PCR. If this patient are going to be fine clinically, most likely, I don't know, there are no data on the outcome. We are looking at data on the outcome. But from a public health perspective, imagine discharging someone telling, don't worry, you are negative, go back to work in your nursing home. What can potentially happen? And even in low clinical suspicion group, be careful because you're still going to miss asymptomatic or even, these are symptomatic, but essentially low symptomatic patients. So be very careful for the perspective. And just to show you an example, this is a patient that I had in my unit. He presented to the emergency department actually because he had some hearing loss, okay? He was hearing loss. He thought that he had a wax in his ear. He presented the triage, he was saturating in the 80s. And because of the time and he was the peak of our wave, because he had, it was not socially distancing appropriately, the suspicion was for COVID. He had the COVID PCR was positive, but a completely normal CT chest. This guy did not have pneumonia on CT. What we found was a PE, interesting enough. And we can discuss a little bit more later about this. So message number 2 is that the SARS-CoV infection does not necessarily correspond to COVID-19 pneumonia. And that's one of the problems by using lung ultrasound and not. Okay, so message is that early detection of interstitial involvement in viral, including COVID-19 pneumonia, it's good. You can use it. Even when chest X-ray is normal, when RT-PCR is negative, because this is going to help you identify the false negative results. So Gabriele and Anthony, I need to hear what you want to do. As you know, my presentation is longer. I was already planning to split it. I can go for other 3-4 minutes discussing a couple of other issues, and then we can stop and continue for the second webinar that we're going to have in a couple of weeks, I believe. Is it okay with you?
I mean, is that because you have to go, right?
Sorry?
Is it because we're getting too long, or because
it's 11:20. I think is that we have 6 minutes left technically. I'm happy to stay longer, but I'm not sure for the panelists or Davide needs to tell us for this. While you discuss maybe in the chat, I keep going.
Okay.
Arif is sum up. Okay, perfect. I'm going to finish in this quick case, and then we are going to go on the sum up. So I call this case something is right part 1. Part 2 and part 3 is going to be discussed at the next webinar. But this was a gentleman in the late 60s, end-stage renal disease, and peritoneal dialysis, hypertension, type 2 diabetes. Again, very, very high risk profile. He was on a medicine ward for known COVID-19 infection, with cough and diarrhea. PCR positive. Initially, no real significant respiratory symptoms, except the cough. It was not hypoxemic. We are called on a Thursday morning, I believe, because of worsening shock and decreased level of consciousness. And this is what we found on lung ultrasound at the time of intubation. Here I'm at the right base. You see here the diaphragm, you see here the consolidation, you see the fusion. I also look at the heart. I have all the views, but I try to summarize for you guys is that this was, what do you think, Gabriele, about this? This is a subcostal short axis view.
Short axis view.
Parasternal was not great, so I went to a subcostal short axis view. What do you think?
It's a very, very small cavities, right and left ventricle, not only in systole, which makes it hyperdynamic kiss in ventricle, but also in diastole. So clearly speaks to a reduced central volemia, maybe due to vasodilation, to hypovolemia, but that's a big...
This patient was in septic shock. Yeah, this patient was in septic shock in the context of right pneumonia. The question is that, is this COVID pneumonia? And for the sake of time, I'm going to tell you is that this is the scenario number 3 that Gabriele and Arif, they are sort of highlighting in their article, is that we have a potential alternative lung disease. This is nothing on this image is suggested of what we showed you before, right? Nothing. This patient had a horrible septic shock secondary to pneumonia. And when I saw those images, I started thinking about superimposed infection. There are some data coming up, is that if you're critically ill patient, 14% of the patient, they have potential co-infection. So be very careful. It's not just only COVID. And in this article from Luna Gargani, she nicely summarized the differences on lung ultrasound between COVID-19 pneumonia, what we already discussed, and the bacterial pneumonia. And again, usually the answer is that the consolidation are larger, and maybe the fusion is also more prominent. There was something on this lung ultrasound that really struck me. Gabriele, if you see this, and this is going to be my last slide before we go to the question and wrap up, is what do you think? If you are like me, Thursday morning, I just intubated this patient, I'm in the isolation room, I'm doing my ultrasound, and I see this, what would you do?
I'd be very worried. I do not only see a lobar, inferior lobe consolidation, I see an image, I see diffusion, but I see hypoechoic areas within it, which speak to a great dishomogeneity, sorry, and that could be a very aggressive pneumonia with abscesses inside. So with the really bad infection. Yeah, you're right.
Correct. This gentleman had a community-acquired MRSA Staphylococcus pneumonia. Okay, so in this specific case, is that I didn't care about the COVID-19. Well, I did care, but the point is that what was killing this patient was not the COVID-19. I saw those features and I right away knew that this patient had a superimposed complication and that is, sorry, I was looking in the chat, someone's asking to put another slide, this one like here. And I started right away bacterial coverage, including Staphylococcus aureus coverage. So a really long ultrasound in this case helped me not having a tunnel vision. It was not just a COVID-19 pneumonia. It was a superimposed, of course. The chest X-ray would have helped in that case after. But as you know, chest X-ray is not always easy. They're not very happy to come in the isolation room, the technician, and sometimes it's complicated. So, and sometimes you don't have availability. In that case, for me, I went in, the patient came down to the ICU, intubated, the line, lung ultrasound, antibiotics, all done. Okay, so I think we can stop
can you
here.
Sum it up for, can you sum it up for us, Alberto?
Yes, so in terms of
summary, very good points.
I am going to my summary slides. And these are the take-home messages for part one. And again, is that I'm hopeful that you will be able to join for part two. And I think is that this webinar has been recorded, and also next one is going to be recorded, so it's going to be available. And my question, remember I started with this question, is that can ultrasound help in a diagnostic approach? Can diagnose the COVID-19 pneumonia? Well, it's great. Lung ultrasound is great. There are definite findings. We discussed about them, the B lines, the light beam, the peripheral consolidation, the irregularity of line and non-significant perfusion, this bilateral diffuse patchy involvement. They correlate very well with CT, and you can also follow this patient up. But the problem is that the specificity is not adequate to me. And again, we need more data.
As far as we know now.
As far as we know now, I cannot tolerate to miss a COVID-19 pneumonia and sending, or even a COVID-19 infection, SARS-CoV-2 infection without pneumonia, and send them to the community. There are possible approaches. If you work, I work a lot with Ethiopia. If you have limited testing and your pre-test probability is high, your lung ultrasound is high, and you have capacity of cohorting this patient, and you have less capacity of RT-PCR, then cohort this patient. Cohort in a sense isolate, don't put in someone in the other circle too, because that can be another problem. Or vice versa. Clinical utility of lung ultrasound PoCUS during the COVID pandemic is that is allowing us the detection, early detection to symptom involvement in viral pneumonia, and the data are there. They can support us to identify those false negative RT-PCR tests that would trick us. Remember, up to 30% of false negative in the literature is sensitive, but not enough to rule out SARS-CoV-2 infection, as we discuss and show you. And of course, it can help identify alternative causes of respiratory failure. And I didn't discuss this, and we may go through the next time, but I can also identify unexpected chronic persisting conditions that are going to significantly help me in managing my patient. If my patient has a biventricular failure that was unknown, if my patient has a severe RV failure in the context of pulmonary hypertension that was unknown, these are all information that ultrasound is getting right away as I'm scanning them for other reasons.
Well, thank you, Alberto. You make very good points and presented great cases. I'm very happy you did so. So I can open the floor to some questions if there are any. Well, that was the famous ultrasound machine.
This one, yes.
Yeah, Alberto's second love. Okay. So are there any questions that you can also make by activating your videos, not only by texting now, if you wish? We are here at your disposals, and some other of the panel may also join.
So there are some questions. So I actually looking on the chat. One question was, can LMB sign presented influenza, bronchiolitis, and other viral diseases? Honestly, I don't have enough experience. I do believe that every time, as I mentioned, every time you have ground-glass opacity, it's on CT. So every condition that can cause ground-glass opacity without a crazy PV pattern, yes, you can have it. So my answer would be go on a radiology textbook, discuss with the radiologist, and look at the differential ground-glass opacity focal without crazy paving. Those are all situations when you may find the light beam. But we need more data. Is that the design was described no more than 2 months ago by Giovanni.
Mm-hmm.
You need to wait at least 5 days after. Yep, go.
Oh, I don't want to prevent anybody from having their question answered. Any other questions from? But I have one question in the end.
There is a question here from Smitesh Gupta asking if you could put the slide on of the COVID pneumonia finding versus the influenza pneumonia and go over that again.
Of course.
The CT scan study by the Japanese or the Chinese group.
Yeah.
Yin Li.
Yeah, I'm sorry, I'm just trying to find it. Voila, it's this one, I assume, right? So in this study, it was a retrospective, but essentially a retrospective analysis. They look at 52 patients with CT scan and confirmed COVID-19, and old cohort of patients with influenza, okay, influenza B, and they have a pair 45. And when they look at the CT characteristics, the distribution of the lesion, peripheral versus central. GGO is ground glass opacities. This crazy paving pattern, as I mentioned, is essentially GGO is ground glass opacity plus thickening on interlobular septa, presence of consolidation. This mosaic attenuation is a characteristic of you see the CT when you have areas that they are normally rated versus that are non-normally rated. The presence of bronchial wall thickening, nodules that are centrilobular, the septal thickening without the GGO, perfusion, air bronchogram, and the fact that it's on bilateral or not. And when I read this slide, is that how can I reliably tell someone this is influenza, this is COVID? Is 70% a bilateral lesion in COVID, 56% they had in influenza. The ground glass 84 versus 71, sure are more, but it doesn't help me. Doesn't help me at all in differentiating the two, and that's what I'm worried. What's going to happen during winter is that we're going to have co-infection, we're going to have single infection. And honestly, I'm very worried about the winter. Winter is coming.
Thank you. There's an interesting question from Ramesh. Ramesh asks, how do you practically use ultrasound with the patients who are suspected having COVID or are known to have COVID in order to protect yourself and the staff? So we're talking about, personal protective equipment and infection spread prevention. How do you do that in Toronto, Alberto?
Well, so far we have been lucky, okay, because we were not overwhelmed. And so despite some limitation in PPE, we have a discrete access. So we do extended use of PPE, but we are not in a situation where we were not able to handle the volume. So I am speaking from a very privileged so far situation. And that is sort of the preamble, is that what we do is that patient we call PUI, person under investigation, that they have or for symptoms or for exposure, because they're coming from a nursing home, they know for sure that they're exposed. They are all treated as isolated patient. So patients that are coming to the emergency department or down the ward that they have any risk of COVID-19 infection exposure, they are managing contact and droplet precaution. That means face shield, surgical mask, gown, and gloves. If I'm doing a aerosol generating medical procedure, we escalate the protection from surgical mask to N95 respirator. I know that we see a lot of centers that use coverall, neck protection. To be honest, is that we were minimalistic in this, focusing a lot of training, focusing a lot of aeration. Our ICU, we moved for the pandemic to a new area of the hospital when the engineering managed to have 9 exchange per hour in every single room. And I think if you read the data from the essentially scientists, physicists that are looking at the diffusion of particles, the environmental aspect, aeration, UV lights, fresh air, it's critical.
But do you also cover the probe and the machine, or do you simply disinfect them?
We use both. I can share with Davide and he can send to the participant. I develop a small sort of a step-by-step approach, pre going in, after when you are inside the room, and after you're sending. Essentially, if we can, we cover. We have covers for the ultrasound. I use the coverage that we use, for example, for ultrasound guided procedures. Correct. If we have a boat, we use a single package gel, and we clean the ultrasound twice. The first time inside the room and the second time outside the room. It's pretty laborious at the point that I have, as many of you guys, I have a handheld device. And so often for a quick dirty assessment, I use a handheld device. When I want to do more ecodynamics, other stuff I'm going to show you in the next webinar, I need to have a higher end machine. And so I had to go in with my higher end machine that requires. So I trust myself. Is that I'm on the floor, they call me on the floor, I quickly do, my daughter just came back, and you can hear she's not happy. And so that's what I do, is that really I decide what is the best ultrasound system for the question that I have for the probe. If the question is that yes, no, dichotomic, I think is a handheld device is great. If instead the question is, okay, what is the RVSP, is patient hemodynamics, then I need a higher hand machine.
Alberto, a couple of questions, if you can still take more. First, if you can, while we speak, show again the slide summarizing lung ultrasound findings in COVID pneumonia. Right? It was one of the first ones. That one, yeah, good.
So for NICAMA is that you can download for free the article for Giovanni Volpicelli on Ultrasound Journal. It's actually the WINFOCUS journal. It's open access, and it's summarized very nicely. The other article that I would recommend to read is from Luna Gargani. It is this one here, European Heart. Actually, my A is missing. There's a typo. Heart Journal Cardiovascular Imaging that also have a very nice tables and descriptions.
And there's another, thank you, Alberto. There's another question. This is from Arif Riyad. Basically, do you recommend repeating lung ultrasound exams in patients who actually have mild symptoms and or who show extrapulmonary signs and symptoms?
So again, disclosure, I don't do any more internal medicine or emergency medicine. And so I don't really have enough exposure to this patient. This would be a great question for Emanuele Pivetta that is looking at this. I can tell you that as the 228 patients that we show you, we managed to have this patient rescan at 30 days. We had to follow up and we are looking at the data. I do believe that there is a potential. We do know that the clinical deterioration happen at 5 to 9 days, right? Is that you develop the symptom day 0 and your clinical deterioration happen at day 5 and 9. Vast majority of my patients that came to the ICU, they were either already on the medicine ward or they were already known to have COVID because they had the test done in the assessment center. They were sent home because asymptomatic and they deteriorated at home. are known to have COVID. So yes, and that would be a cool question to answer, is that can, by using lung ultrasound, predict early? There's another article published many years ago by Luna Gargani on peak model of ARDS, uric acid induced, was showing that the B lines that were appearing earlier than oxygenation changes. So can you imagine is that in an ideal scenario is that I diagnose someone with COVID, there is no interstitial signs, so there are interstitial signs, I follow this patient, they can even scan themselves, as a lot of emergency physicians demonstrated during the pandemic. There are nice case series published in the literature. And if a certain threshold may be combined with SpO2 is rich, this patient should start proning himself or should come to the hospital earlier and preventing those crashing intubation. I don't know. There's a lot of things that we can learn.
Yeah, the perspective may change according to the phase of the journey of the COVID patient you actually step into. And this would affect the studies, the experiences. So that's why it's so good to share this among different specialties.
I think
so
this webinar,
ER, intensive care.
And just a comment about these webinars is that thank Anthony, thanks Davide, thank Gabriele for organizing them. But I think there is a huge potential for sharing experiences, discussion. I look forward for the next one from Brett, and I really look forward to coming back because I'm learning from your question, guys. That's the funny part, as usual.
Thanks, Alberto. Well, we are greeting everybody and texting back a couple of answers. So all your answers will be, all your questions will be answered. Don't worry. Okay. And in any case, you could write further to the secretary if you have any relevant question to be back. We will forward it to Alberto and to the other panelists.
And I'm just pointing my email. So feel free to directly reach out to me if you have any specific question. If you need material, I will be more than happy to get in touch with you privately.
Great. I think we need to conclude now. And I want to thank you all. It was really not only interesting, but was good fun. And thank you for the perfect logistics, Davide, Anthony, Quim, and all that are behind the scenes working for this. I'm happy that you attended so numerous, and we wait for you to come back again on the incoming webinars. They're going to be a couple of days, the 6th of August and the 13th likely. We still have to finalize the details. Don't worry, we'll forward you through the mail that actually you contacted the secretary with and you've been in touch with, the exact dates and the topics. Other great speakers will join us. There's going to be Brett Nelson, New York Emergency Medicine, and Alberto will be back with his second part. And the series will go on along next weeks and months. So thank you so much, everybody. Stay safe and bye-bye.
Bye. Thank you. Thank you so much, everyone. It was such a pleasure.
Bye,
thanks, Gabriele. Thanks, Davide. Thanks,
Bye.
Anthony.
Bye.
Bye, everyone.
Thank you, Alberto and Gabriele. Thank you.
Bye.
Goodbye.